is also referred to as antibody. And these are substances that are produced by the plasma cell, that is the B lymphocytes of the body. They produce the antibody referred to as immunoglobulin. And they are the essential part of the adaptive immunity in humans. So, and specifically, they bind the unique antigenic epitope, which are also called the antigenic determinant. All right, and they possess antigen binding sites. The antigen binding site is what the antigen binds to on their body. So members of this class is generally referred to as immunoglobulin. Looking at how an antibody look like, I wish I can share this slide. We'll have been able to see the picture. But from our knowledge of immunology, there are some of these things I believe we already have. That is, they have to identify identical heavy chains. They have to identical light chains. They have each of the heavy chain has a constant and a variable. Also, each of the light chain has a constant and a variable. And typically, the structure of an immunoglobulin, we have the fragment antigen binding section, and we have the fragment constant section. So when papain reacts on it and breaks into two, it breaks into Fab and FC. The Fab is the fragment antigen binding, and then the FC is the fragment constant. So digestion with the enzyme papain produce the two, and one crystallizable fragment FC and two antigen binding fragment called FAB, which are responsible for the functions of immunoglobulins other than the direct binding of the antigens. So the FAB region has a variable region, is the variable region of the antibody. The FAB is the variable region of the antibody, is the tip of the antibody, is the one that binds the antigen, and is specificity of antigen binding determined by the VH and then the heavy V and the low V. That is heavy variable and the low variable section of the immunoglobulin. Generally, antibody exists in two forms. They exist in two forms. Number one, they exist in the soluble form, which are the ones that are secreted in the blood and in the tissue. So antibody exists in the soluble form. And then in the second form, it exists as a membrane-bound antibody. It exists as a membrane-bound antibody, which are found on surface of B cells. And they are also known as B cell receptor. They are known as B cell receptor. So generally, antibody exists in two forms, soluble form and the membrane-bound form. Both the heavy and the light chains contain relatively variable V and the constant C regions with regard to the amino acid composition. So the amino acid composition makes a difference from one immunoglobulin to the other. The variable light and the constant light are the general terms for these regions on the light chain, while the variable heavy and the constant heavy specify variable and constant region on the heavy chain of the immunoglobulin. From our immunological background, you will agree with me that we have 5 major classes of immunoglobulin, and this depends on the heavy chain makeup of each of the immunoglobulin. So the immunoglobulin are differentiated into 5 major classes based on the heavy chain makeup of each of the immunoglobulin. Take, for instance, number 1, we have the hemoglobin G, which is the IgG. IgG is made up of heavy chain gamma. Is made up of heavy chain gamma. And then we have the IgM, which has the mu heavy chain. We also have the IgA. It has the alpha heavy chain. We also have the IgD, which has the delta heavy chain. We have the IgE, whose heavy chain is called the epsilon. So the different heavy chain differentiate immunoglobulin majorly into these 5 different classes. So if we want to take them one by one, if we want to take IgG that has the heavy chain of gamma now, it's a monomer. IgG is a monomer form of immunoglobulin and is the major class of immunoglobulin in the serum. In fact, 70% of total immunoglobulin in the serum, they are IgG. 70% are IgG. Is the main antibody in the secondary response. I'm sure we are familiar with primary response, primary exposure, and the individual develop an antibody, and then that's the primary response. When the fellow is reintroduced to the same antigen, it elucidates a secondary response. So IgG is the one implicated in secondary response in immunology. and it constitutes important defense against bacteria and viruses. So IgG constitutes important defense against bacteria and viruses. And it's the only antibody that crosses the placenta. So in immunologic disease of newborn, it is the IgG resus D antibody that crosses the placenta that causes immunologic disease of a newborn. So it's the maternal antibody that protects the fetus. IgG is the maternal antibody that protects the fetus, apart from case of hemolytic disease of a newborn. That is for IgG. Let's look at IgA, whose heavy chain is alpha. IgA also is either a monomer or dimer, and it occurs in two forms. IgA occurs in two forms. We have the secretory IgA, that is a dimer, and we have the serum, which is the monomer IgA. Serum IgA, then the secretory IgA. The second most abundant class in the serum is IgA, and it's about 20% of the serum constitution of immunoglobulin. And the major component of colostrum, which happens to be the first milk the mother produces after delivery, the colostrum, IgA happens to be the major component of colostrum. And they are the secretory antibodies. So they are present, therefore, in saliva, they are present in tears, they are present in respiratory, intestinal, and genital secretion. So IgA, the secretory forms, occur more in saliva, tears, respiratory, intestinal, and genital secretion. This IgA protects mucous membrane from antigenic attack. That's explained their presence on the respiratory section, on the intestinal section, and the genital section. Their presence, protect against antigenic attack on those surfaces. In a dimer form, the J chain connect the monomers. That's for IgA. As I said, it occurs in two forms, the secretory forms and the serum form. The next one we'll look at is the IgM, whose heavy chain is mu. The heavy chain of IgM is mu. IgM is a monomer or a pentamer. It's the only immunoglobulin that is a pentamer. It's the only immunoglobulin that is a pentamer. So it's either a monomer or a pentamer. And then 8 to 10% of normal serum immunoglobulin are due to IgM. It constitutes about 8 to 10% of the normal serum immunoglobulin. And they are produced early in the primary response to an antigen. So they are implicated in primary response. When there is initial exposure to an antigen, it is IgM that is primarily produced. And then it activates complement. It activates complement. In addition to that, it promotes phagocytosis. IgM promotes phagocytosis. And IgM also causes lysis of antigenic cells. That is in bacteria. It causes lysis of antigenic cells in bacteria. Then we have the next group that we call the IgD, which is whose heavy chain is the gamma. And IgD itself is a monomer, just like IgG. And IgG constitutes about 1% of the immunoglobulin in the serum. It constitutes just about 1%, less than 1% of the immunoglobulin in the serum. In IgD, there is no known antibody function, at least for now, no known antibody function. And the IgD may function as an antigen receptor, and it is labile molecule. It's a labile molecule. IgD is a labile molecule. Here we have IgE now. IgE. IgE here exists as a monomer. It exists as a monomer. IgE epsilon is the heavy chain of IgE, epsilon. It exists as a monomer, and then it occurs in a very trace amount in the serum at a value of about just 0.004% in the serum. So IgE has been implicated in allergic reactions, and it binds very tightly on basophils and mast cells. Basophils and month third. So if you want to talk about the sequential IgM and the IgG humoral response, IgM, they are produced as the first response to many antigens, and the levels remain high transiently. The level of IgM remain high transiently. The moment IgG takes over, which are produced after IgM, then higher level of IgG results into lower level of IgM. So IgG higher level persists in small amount throughout life, and they are produced in large amount during secondary response, as I said earlier on. But persistence of antigen-sensitive memory cells after primary response is due to IgG. So most of the memory cells, sensitive memory, antigenic sensitive memory cells are due to IgG. Just to give an explanation of how this response occurs, primary and secondary immune responses. When an antigen is injected, antibodies in the blood appear within about 10 days. Definitely that will be IgM. And they reach a peak level within 20 days. And this response declines by about 30 days. So the IgM molecules will be predominant in this primary response. Now, when this same antigen is now re-injected into the same animal, eliciting a second response, after a few months, the antibody response will be quicker this time around. It will be within 3 days compared to the 10 days of the primary response. For the second response, within 3 days, there is a quick response because the antibody is already there. And this time around, the response becomes stronger, 100 to 1,000 times more the quantity of the antibody. And in this second response, it is more active. And it is IgG type that is in the second response. And it is more prolonged, that is response lasts for months. So this one is the secondary immune response, which is due to the memory cells produced in the primary response stage. So active immunity is induced by immunization with toxoid or killed or attenuated organisms. And examples are diphtheria, pertussis, tetanus, DPT vaccine, oral polio vaccine, and hepatitis B vaccine. So these are under the category of the active immunity that are induced by immunization in individuals. We have passive immunity, whose protection is given by preformed antibody. Antibody that have been formed. And this is used in immunotherapy against diphtheria, against tetanus, against so I have just explained active immunity and passive immunity. Now, maybe we begin to look at the infection in immunoglobulin generally. Let's look at the first, what we call the hypergammaglobulinemia. Hypergammaglobulinemia. This is an uncommon condition that is usually the result of an infection. It's not a common infection. It normally results as a result of an infection. It's usually an autoimmune disorder or a malignancy, such as multiple myeloma. Multiple myeloma is an example of autoimmune disorder, and these are examples of a hypergammaglobulinemia. It is characterized by elevated levels of immunoglobulins in the blood. Now, what could be the cause of hypergammaglobulinemia? It could be as a result of chronic infections where antibody production is high. An example are leprosy, tuberculosis, syphilis, malaria, chalazia, and then some acute bacterial endocarditis. So these are typical examples of chronic infections that will result in hypergammaglobulinemia. It also occurs as a result of aberrant immune reactions, such as rheumatoid arthritis, collagen disorders, glomerulonephritis. Examples, autoimmune disorders where cryoglobulins may also be present. There are autoimmune disorders where cryoglobulin also may be present. So these are other causes of hypergammaglobulinemia. hypergammaglobulinemia. And also paraproteinemia, such as in multiple myeloma and Waldenstrom's macroglobulinemia, are conditions also categorized under the hypergammaglobulinemia that will result in hypergammaglobulinemia. Paraproteinemia, such as multiple myeloma and Waldenstrom's macroglobulinemia. Also, monoclonal gammopathy of undetermined significance, we call it MGUS. MGUS, monoclonal gammopathy of undetermined significance. This is also characterized by hypergammaglobulinemia and M-bound on electrophoresis. When the electrophoresis is carried out, it follows the M-bound on the paper or the membrane used. So these patients do not have any end organ disease like anemia or bone involvement. The plasma cell in bone marrow is less than 10%. They, however, have a higher chance of progressing to multiple myeloma. So monoclonal gammopathy of undetermined significance has the tendency of progressing to multiple myeloma. Now, looking at a multiple myeloma itself, which we normally call plasmacytoma, when the immunoglobulin secreting cells are transformed into malignant cells, one clone alone is enormously proliferated. And that's what we see in multiple myeloma. A clone of the malignant immunoglobulin will be enormously proliferated. And this Ig molecule of the same type, they are produced in such a large quantity that we can easily see it on electrophoresis as the myeloma band or the monoclonal band or M band. So the M band is referred to as the myeloma band or monoclonal band on the electrophoresis band membrane that is used, with a very sharp, narrow spike when you carry out the electrophoresis because of the quantity of the malignant clone immunoglobulin group that is implicated. So in multiple myeloma is characterized by a paraproteinemia anemia, and then lytic bone lesions and proteinuria, that is protein in the urine. And the bone marrow examination reveals large number of malignant plasma cells as diagnosis of a multiple myeloma. And then we have raised beta-2 microglobulin, which is another feature of multiple myeloma during the electrophoresis. The molecular weight of the raised beta-2 microglobulin is 11,800. And then the total Ig content may be very high, but useful antibodies may be very low, so that general immunity is depressed and recurrent infections are common. What we are trying to explain, because of the increase in the production of their malignant and the abnormal immunoglobulin, the useful immunoglobulin production will be reduced. Is this other one that will be increased. Thereby, the normal immunity that the body is supposed to derive from the antibodies will be compromised, and the fellow will be exposed. We have general immunity, depression, and be exposed to infections, common infection. The prognosis of multiple myeloma is generally good. An average survival is more than 5 years with adequate chemotherapy and local radiation. Some people used to take it to be as a form of cancer, not really cancer, but as a form of cancer. It's under the category of the myeloproliferative disorders. Another infection we want to look at under this is the Bence-Jones protein, Bence-Jones proteinuria. Henry Bence-Jones happens to be the man that in 1848 described this disorder that we refer to today as Bence-Jones disease. You know, in this disorder, 20% of patients with multiple myeloma produce Bence-Jones protein. So monoclonal light chains are excreted in the urine, and this is due to the asynchronous production of the heavy and the light chains, or due to the deletion of the portions of the light chain so that they cannot combine with the heavy chains. So the problem is the combination of the H and the light chains. So abnormality comes in, and then there will be increased production of the monoclonal light chain, and this will be excreted in the urine. So the Bence-Jones protein have this special property of precipitation when heated between 45 degrees centigrade and 60 degrees centigrade. They will precipitate. and they will redissolve at a higher temperature than 80 degrees centigrade. And when you cool them down, cool the solution down at less than 45 degrees centigrade, as less than 60 to precipitate, and then it also redissolve at less than 45 degrees centigrade. So I repeat, it has this unique property. It precipitates between, when you subject it to heat, it will precipitate between 45 degrees centigrade to 60 degrees centigrade. By the time you heat to 80 degrees centigrade, it will be redissolved. And before you get to 45 degrees centigrade, or if you are cooling down, by the time you get to 45 degrees centigrade, the precipitated form of 60 to 45 will also redissolve. So this protein that's one of the diagnostic tools of Bence-Jones protein. This protein may block kidney tubules, leading to renal failure. So myeloma with Bence-Jones protein has poor prognosis. There is a test that we normally use for it. We call it the Bradshaw test. Bradshaw test is also positive for multiple myeloma, for Bence-Jones protein. When a few ml of urine is layered over a few ml of concentrated hydrochloric acid, a white ring of precipitate is formed for Bence-Jones protein. That test is referred to as Bradshaw test. Now, how useful is electrophoresis of serum and plasma protein? How useful it is at a pH of 8.6. As we know, electrophoresis generally are used to study protein abnormalities and the separation of protein. Serum is a better choice for electrophoresis because the fibrinogen of plasma gives a discrete band which can easily be mistaken for paraprotein. So if you want to carry out electrophoresis, the sample of choice is serum, because we have found out that if you use plasma, the fibrinogen content of plasma will give a discrete band which you can easily mistake for paraproteins. So it shows order of migration along horizontal axis with proteins of highest mobility closer to the anode, while the protein of lowest mobility will be closer to the cathode when they are being separated by electrophoresis. The height of the band along the vertical axis shows the protein concentration when it's carried out. And the location of some major proteins are also indicated underneath their electrophoretic mobility peaks. Those ones are for control. And electrophoresis can also show gross deficiency or excess of immunoglobulins and whether paraproteins are present. Then quantitative measure of each protein class may be obtained by scanning electrophoretic strip. So when you get your slide, you will see the electrophoresis of serum proteins. The pattern is the theme. The one that has the normal pattern, the one that has the presence of paraprotein, and the one that has the presence of a paraprotein band, different types of paraprotein band. You will see it when you receive the slide. And then when you scan the electrophoretic strip, you'll be able to distribute them into the albumin and then the various categories of the immunoglobulin. That scan of an electrophoretic strip is also in our slide. So that is the best. I want to talk to us about immunoglobulin structure and infection. Let's now go to autoimmunity. Autoimmunity. Okay. All right, let me finish with that. I was thinking we'll go to mediators of cellular immunity. Let me see. All right. Let's go to mediators of cellular immunity. Mediators of cellular immunity. Just a follow-up to our immunology lecture. In our immunology, we've been told what an antigen is, what an antibody is, how antigen elucidates production of antibody, different type of antibody that we have just discussed under immunoglobulin. So the cell-mediated and the other type. So we'll be looking today fully on the mediators of cellular immunity. And we'll start by looking at cell-mediated immunity. Cell-mediated immunity is defined as the immunity that is developed by cell-mediated response. They are the immunity developed by cell-mediated response. So as the name goes, cell-mediated. So is the immunity developed by cell-mediated response. And it's also called cellular immunity or T-cell immunity. Cell-mediated immunity is also called cellular immunity or T-cell immunity. It involves several types of cells, such cells as T lymphocyte. Under cell-mediated, we have cells like T lymphocyte, we have the macrophages, we have the natural killer cells, and these are cells that are implicated under the cell-mediated immunity. Cell-mediated immunity does not involve antibodies. It is majorly cell-mediated. It does not involve antibody. And cellular immunity is the major defense mechanism against infections by viruses, by fungi, and a few bacteria like tuberculous. And it's also responsible for delayed allergic reactions and the rejection of transplanted tissues. Also, cell-mediated immunity is offered by T lymphocyte, and it starts developing when T cells come in contact with the antigen. So in this case, T cells is the antigen, carries the antigenic site, that when it gets in contact with the antigen, the cell-mediated immunity starts up. Usually the invading microbia or the non-microbial organism carry the antigenic material. And when they come in contact with the T cells, there is antigenic immunoglobulin production, the response. So these antigenic materials are released from invading organisms. So the organism carry the antigenic material. They could be bacteria and they could be microbia or non-microbia, but they bring in the antigenic material. And when they invade the cell, the antigenic materials are presented to the helper T cells by antigen presenting cells. So it is the antigen presenting cells that help to present the antigenic material to the helper T cells. So now let's look at the different types of antigen presenting cells. I've just explained that it is the antigen presenting cells that will present the invading antigenic material to the helper T cells. So now let's look at the different types of antigen presenting cells. One example is what we call the macrophages. Macrophages happens to be the number one type of antigen presenting cells that help to present the antigenic material to the helper T cells. The second type of antigen presenting cell is what we call the dendritic cells. The dendritic cells. And then the third form is the B lymphocyte. So among these cells, that is among the macrophages, dendritic cells, and the B lymphocyte cells, which are the three major types of the antigen presenting cells, the major antigen presenting cell is the macrophages. So macrophages, it happens to be the major antigen presenting cell. They are the large phagocytic cells. We digest the invading organism in order to release the antigen. The principle of action of a macrophage is that it phagocytoses the antigenic site and the organism and digest the invading organism to release the antigen that is on the organism. The macrophage are present along with lymphocytes in almost all the lymphoid tissues of the body. They are present in almost all the lymphoid tissues of the body. So macrophage work by phagocytic principle. It will phagocytose the organism, the cell, and then inside it will digest the organism and release the antigenic site. For dendritic cells are non-phagocytic in nature. They are non-phagocytic in nature. Their own principle is based on the location. That is, dendritic cells are classified into three categories based on their location, based on where they are, where they occur in the body of the. Remember, it does not act by phagocytosis. But how does it act? Dendritic cells of spleen, they act by trapping the antigen in blood. His own principle is by trapping. Macrophages is phagocytosis, but dendritic is by trapping. It traps the antigen in the blood. The dendritic cells of the spleen trap the antigen in the blood. The follicular dendritic cells in the lymph node trap the antigen in the lymph. The Langerhans dendritic cell in the skin trap the organism coming in contact with the body surface. So its own principle of action is by trapping. The third category of the antigen presenting cell is the B lymphocyte. And it's found that B lymphocyte also acts as antigen presenting cell. Thus, the B cell function as both antigen presenting cell and antigen receiving cell. So B lymphocyte now act as antigen presenting cells and also act as antigen receiving cells. However, B cells are the least efficient antigen presenting cells, and they need to be activated by hepatocyte cells. They need to be activated by hepatocyte cells for them to act effectively as an antigen presenting cell. Now let's look at the role of antigen presenting cell in totality. When we bring them together, it is very foreign organism, either by engulfing by macrophage through phagocytosis or by trapping by dendritic cells. Later, the antigen from this organism is digested into small peptide products, and these antigenic peptide products move toward the surface of the antigen presenting cell and bind with human leukocyte antigen, HLA. And this human leukocyte antigen is a genetic matter present in the molecule of class 2 major histocompatibility complex, which is situated on the surface of the antigen presenting cell. So on the surface of the antigen presenting cell, there is a molecule called the class 2 major histocompatibility complex. That's what the human leukocyte antigen will present the antigen to. Remember, we said they will invade, they will engulf or trap and digest the organism by releasing the peptide antigen. This antigenic peptide will move toward the surface of the antigen presenting cell, and they will bind with human leukocyte antigen that is on the antigen presenting cell. And then this human leukocyte antigen that is binding with the antigenic peptide will now present this particular combination to the molecule of class 2 major histocompatibility complex, which is also situated on the surface of the antigen presenting cell. And then B cells will ingest the foreign bodies by means of pinocytosis. So the role of B cells as antigen presenting cells in the body is not as explicit as that of macrophages and the dendritic cells. So major histocompatibility complex is a large molecule present in the short arm of the chromosome 6. It is made up of a group of genes which are involved in the immune system, and it has more than 200 genes, including human leukocyte genes, human leukocyte itself, that is made up of genes with small molecules. So it encodes antigen-presenting proteins on the cell surface of the antigen-presenting cell. So though major histocompatibility complex molecules and human leukocyte antigen genes are distinct terms, both are used interchangeably when you are referring to the surface of the antigen-presenting cell. So particularly in human beings, the major histocompatibility molecules are often referred to as the human leukocyte antigen molecules. In human beings, the major histocompatibility complex molecules are divided into two types. We have the class 1 MHC molecule and the class 2 MHC molecule. The class 1 MHC molecule is found on every cell in human body, and it is specifically responsible for presentation of endogenous antigens, that is, antigens that are produced intracellularly, such as viral proteins or tumor antigens. So the class 1 MHC molecule presents this endogenous antigen to the cytotoxic T cells. We have mentioned hepatocyte cells now. Now we are also talking about the cytotoxic T cells. So it is the class 1 MHC molecule that we present this endogenous antigen that are produced intracellularly to this cytotoxic T cell. The class 2 major histocompatibility molecule is found on B cells. So macrophages are not antigen-presenting cells. It is found on B cells. This class 2 is found on B cells. It's also found on macrophages and other antigen-presenting cells, which is dendritic cells. It is responsible for presenting the exogenous antigens. These are the antigens of bacteria or viruses which are engulfed by antigen-presenting cells. The first one, the class 1, has to do with endogenous antigen, but the class 2 MHC molecule present exogenous antigen. So to helper T cells, the first one presents as endogenous to cytotoxic cell, T cells, but the second one produces exogenous antigen, which are antigens of bacteria or viruses which are engulfed by antigen-presenting cells to helper T cells. Presentation of antigen now. Antigen-presenting cells present their class 2 MHC molecule together with antigen-bound HLA to the helper T cell, and this activates the helper T cell through series of events. The events are as follows. Helper T cell will recognize the antigen displayed on the surface of the antigen-presenting cell with the help of its own surface receptor protein called the T cell receptor. And then recognition of this antigen by the helper T cell will now initiate a complex interaction between the helper T cell receptor and the antigen. And this reaction will now activate the helper T cells. And at the same time, the macrophages, which are the antigen-presenting cell, will release interleukin-1. Interleukin-1 will facilitate the activation and the proliferation of the helper T cells. So the activated helper T cells now will proliferate, and the proliferated cells will enter the circulation for further actions. Simultaneously, as these reactions occur, the antigen which is bound to the class 2 MHC molecule will also activate the B cells also, resulting in the development of what we call humoral immunity. Humoral immunity. So this is the sequence of events during the activation of a helper T cell that result into development of humoral immunity. What's the role of the cytotoxic T cells? The cytotoxic T cells are activated by the helper T cells, and they circulate through the blood, through the lymph, through the lymphatic tissues, and they destroy the invading organism by attacking them directly. So cytotoxic T cells invade and destroy the attacking organism by attacking them directly. The invading organism by attacking them directly. What's the role of the helper T cells? On its own, these helper T cells activate all the other T cells and B cells. And that brings us to the CD4 count. The normal CD4 count in healthy adult varies between 500 to 1,000 per cubic millimeter of blood. In a situation where the CD4 is less than 200, then those are AIDS patients, HIV positive patient AIDS. The CD4 is less than 200. But if the CD4 is between 500 to 1,005, is a normal patient. We also have what we call the suppressor T cells. The suppressor T cells. The suppressor T cells are also called the regulatory T cells. And what it does is to suppress the activities of the killer T cells. So the suppressor T cell plays a major role, an important role, in preventing the killer T cells from destroying the body's own tissues along with the invaded organism. The killer T cells, they attack the invaded organism. As they try to destroy the invaded organism, it is the suppressor T cell that will control the killer T cell from destroying its own body tissues. So it acts as a regulatory T cells. So suppressor cells, T cells suppress the activities of helper T cells also. Then we have the memory T cells. Some of the T cells activated by an antigen do not enter the circulation, but they remain in the lymphoid cell. And these T cells are called the memory T cells. They don't enter into circulation. They remain in the lymphoid tissue. And their presence in the lymphoid tissue makes them the memory T cells. In later periods, These memory cells will migrate to various lymphoid tissues throughout the body. So when the body is now exposed to the same organism for the second time, it is these memory cells in the lymphoid tissue that we identify the organism, and we immediately activate the other T cell. So the invading organism is destroyed very quickly. So the memory, that's the function of the memory T cells that remains in the lymphoid tissue. When there is an exposure to the same organism, it activates the other T cell. So the invading organism is quickly destroyed. And then the response of the T cell is also more powerful this time around. So those are the things. You will see some other pictures that give us. We have the T cell, the virus infected cell. We have the close of the T cell. We have the picture that shows the suppressor T cell will protect the LD cell. The memory T cell will persist in the bloodstream in the lymphoid tissue to protect against tissue infection. The helper T cell, which boosts immune response by activating killer T cells and stimulating antibody production by B cell. And then the killer T cell itself that destroy the virus infected organism. So let me take one more. We have taken immunoglobulin. We have taken mediators. Okay, let me take. Let's take. Okay, let's take hypersensitivity. 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 Hypersensitivity refers to an undesirable reaction that are produced by the normal immune system, including allergies and autoimmunity. So the big word brings together allergic reactions and autoimmune reaction. Is an undesirable reaction that are produced by the normal immune system of the individual. And the reaction may be damaging, highly uncomfortable, or even occasionally can be fatal. The reaction can be damaging, highly uncomfortable, and sometimes can be fatal. And then they are classified, hypersensitivity are classified into different groups. We have type 1, we have type 2, we have type 3, we have type 4 of hypersensitivity. So we'll take them one by one. Type 1 is the immediate anaphylactic or the atopic anaphylactic. That is the type 1. The type 2 is antibody dependent. That one depends on antibody. The type 3 hypersensitivity is immune complex. And the type 4 is a cell-mediated or delayed type of hypersensitivity. So let's take type 1 of hypersensitivity now, which we call the immediate or the anaphylactic hypersensitivity. The type 1 hypersensitivity is also known as immediate or anaphylactic hypersensitivity, and the reaction may involve skin. If the reaction occurs in the skin, we have issues like urticaria rashes and eczema. It can also, the reaction of immediate or anaphylactic hypersensitivity can also occur in the eyes. When it occurs in the eyes, it leads to conjunctivitis. It can also occur in the nasopharynx of the lung. And when it occurs in nasopharynx, we have the rhinorrhea or the rhinitis. It also occurs in the bronchopulmonary tissues. And when this hypersensitivity occurs in the bronchopulmonary tissues, it results into what we call asthma. And it can also occur in the gastrointestinal tract. And when it occurs in the gastrointestinal tract, it results into what we call gastroenteritis. So the reaction of immediate or anaphylactic hypersensitivity can occur in all different areas that we have mentioned. And the reaction may cause a range of symptoms, from minor inconvenience to even death. And the reaction usually takes 50 to 30 minutes from the time of exposure to the antigen. Although sometimes it may have a delayed onset, that is, it can stay for 10 to 12 hours. It is usually mediated by IgE antibody to specific antigen. It's mediated by IgE antibody to specific antigen. And the primary cellular component in this hypersensitivity is the mast cell or the basophil. That is the primary cellular component that is involved in this form of class 1 or type 1 of hypersensitivity. It is the mast cell or the basophil that are involved. And the reaction is usually amplified or are modified by platelets, neutrophils, and eosinophils. And mast cells, as you know, are stimulated and release, has the ability to stimulate and release histamine. Histamine are stimulated and released from mast cells. Now, what are the common causes of type 1 hypersensitivity? Allergen and non-parasite allergens. Allergens are non-parasite antigens that can stimulate a type 1 hypersensitivity response. So we have allergen as a common cause, of type 1. Our common allergens associated with type 1 hypersensitivity are under protein. We have the foreign serum, we have the vaccines. Under plant pollens, we have the ryegrass, we have the ragweed, Timothy grass, or birch trees. Under the category of the drugs, we have things like penicillin, we have sulfonamides, we have local anesthetics, and we have the salicylates as drugs that can cause allergic type 1 hypersensitivity. And the other food, we have nuts, we have seafood, we have eggs, we have peas, we have beans and milk. And then under insect product as the category of common allergens, insect product, we have bee venom, we have wasp venom, we have ant venom, we have cockroach calyx, and we have dust mites. And then we have certain mold spores and some animal here and then there. So these are the common allergens associated with a type 1 hypersensitivity. What is atopy? Atopy, A-T-O-P-Y. We mentioned it earlier on. Atopy is the term for the genetic trait to have a predisposition for localized anaphylaxis. It is a term that is used for the genetic trait to have a predisposition for localized anaphylaxis. So therefore, atopic individuals, they have higher level of IgE and eosinophils. They have higher level of IgE and eosinophils. Let's try and look at the mechanism of type 1 hypersensitivity. Mechanism. Number one, the initial introduction of the antigen in type 1 hypersensitivity produces an antibody response. And more specifically, the type of antigen and the way in which it is administered induce the synthesis of Ig antibody in particular. So the synthesis of IgE antibody that is produced is specifically related to the type of antigen and the way in which the antigen is administered. So the immunoglobulin IgE that is produced bind very specifically to receptors on the surface of the mast cells, which remain in the circulation. So reintroduce antigen now will interact with the IgE on the mast cells, causing the cell to degranulate and release large amount of histamine or lipid mediators and chemotactic factors that cause smooth muscle contraction or vasodilation or increased vascular permeability or bronchoconstriction and edema in cases of asthma. And all these reactions occur very suddenly and they can cause death. So this is the mechanism by which type 1 hypersensitivity usually occur. So what are the mediators of type 1 hypersensitivity? The mediators are histamine, cytokines, chemoattractants for neutrophils and eosinophils, enzymes like tryptase, kinase, and cathepsin, and then changes in connective tissue matrix or tissue breakdown. Also, we have leukotrienes and then prostaglandins. These are the mediators of a type 1 hypersensitivity. What are the common diagnoses? The diagnostic test for immediate hypersensitivity, that is type 1 hypersensitivity, includes skin prick, and intradermal test, or measurement of total IgE or measurement of specific IgE antibody against suspected allergens. So if you are suspecting a particular allergen, you can wash out and analyze for the specific corresponding IgE antibodies. And then total IgE and specific IgE antibodies are also measured by a modification of enzyme immunoassay, that is ELISA method. Increased IgE levels are indicative of an atopic condition, that is individual that has the predisposition to developing a type 1 hypersensitivity. Although IgE may be elevated in some non-atopic diseases, so there are some non-atopic diseases that IgE also increased. In situations like emetic infection, that is worm infection, or myeloma. We have treatment here. I just put it there for us. Drugs. It is not steroidal anti-inflammatory that are usually used. Antihistamines, that is the blood histamine receptors, steroids. These are the ones that are easily used. And then immunotherapy is another method, in which case desensitization by hyposensitization, as also known as allergy shots, are also used for treatment. And then repeated injection of allergen to reduce the IgE on the mast edge and to result into production of IgG is another line of treatment. That is much we want to talk about the type 1 hypersensitivity. So let's look at a type 2 hypersensitivity. Type 2 hypersensitivity is also known as cytotoxic hypersensitivity and may affect a variety of organs and tissues. It is also known as cytotoxic hypersensitivity and may affect a variety of organs and tissues. The antigens are normally endogenous. That is, like I said earlier on, those are the enzymes produced by intracellular cells. Although exogenous chemicals like actins occasionally can attach to cell membrane and can also lead to type 2 hypersensitivity, but generally it is normally due to endogenous production. We have drug-induced hemolytic anemia. Example, granulocytopenia and thrombocytopenia. These are drug-induced. Examples of drugs implicated are penicillin. Penicillin allergy also results to this drug-induced hemolytic anemia and therefore belong to this class. The reaction time is minutes to hours in type 2 hypersensitivity. The reaction time is minutes to hours. And type 2 hypersensitivity is primarily mediated by antibodies of the IgM or IgG classes and complement. So phagocyte may also play a role in type 2 hypersensitivity. And the lesion contains antibody complement and the neutrophils. Let's look at conditions that are under the type 2 hypersensitivity. One is hemolytic disease of newborn, which is resource factor incompatibility. IgG antibodies to resource and Incoccus red blood cell antigen. Resource positive baby that are born to resource negative mother first time are always fine, but the second time can have antibodies to resource from first pregnancy. So when the antibody crosses the placenta, it has the tendency of killing the baby red blood cells. And mothers that are treated with antibody to the resource antigen, right after the initial birth, they don't make immune response. They never make their own immune response. So that's why we recommend whoever is resource D negative, they should give them from the council at the antenatal level, that the moment they give birth to a child, the moment they find out that that baby is resource D positive, the mother must be given resource D antigen, which is usually referred to as a ROGAM. That will boost the immunity of the woman and make the woman to produce antibody. It will not make the woman to, the ROGAM will mob the invaded resource D positive cells into the body of the mother. The ROGAM will mob it up, will not allow the mother to be able to respond by immune. It will not be able to give an immune response to that resource D. So the mother will not have resource D antibody. So even when she gets pregnant again, and this time around the baby is resource D positive, no resource D antibody will have been produced that we want to cross the placenta to kill the red blood cells of the inborn. Diagnosis tests for this type 2 include detection of circulating antibody against the tissues involved, and then the presence of antibody and complement in the lesion by immunofluorescence. And then the staining pattern is normally smooth and linear, such as that seen in a good pastures nephritis, which are renal and lung basement membrane. And then their treatment involve anti-inflammatory and immunosuppressive agents. In type 3 hypersensitivity, antigen antibody immune complexes are involved. Is antigen antibody immune complexes and IgG mediated. Large amount of antigen and antibodies form complexes in blood. And if they are not eliminated, they can deposit in capillaries or joints, and they can trigger inflammation. The reaction may be general in type 3, e.g. serum sickness, or may involve individual organs, including skin, e.g. systemic lupus erythematosus, or Athos reaction. And it could be involved in kidney disease like lupus nephritis. It could also be involved in lung disease like aspergillosis. It could be involved in joint diseases like rheumatoid arthritis or other diseases of the organs of the body. And the reaction may be the pathogenic mechanism of diseases caused by many microorganisms. In this type 3, the reaction may take 3 to 10 hours after exposure to the antigen, and it is mediated by soluble immune complexes. They are mostly of the IgG class, although IgM may also be involved, but they are mostly of IgG class. The antigen may be exogenous, that is in chronic bacterial and viral parasitic infections, or may be exogenous in cases of non-organic specific autoimmunity, e.g. systemic lupus erythematosus, SLE. And the antigen this time around is soluble and not attached to the organ involved. PMNS and macrophages bind to immune complexes via FCR and phagocytose the complexes. But if it's unable to phagocytose the immune complexes, it can cause inflammation via the complex activation pathway, that is C3A to C3 to C4A to C5A, and so on and so forth. Diagnosis of this type 3. Diagnosis involve examination of tissue biopsies for deposit of immunoglobulin and complement by immunofluorescent microscopy. And also the presence of immune complexes in serum and depletion in the level of complement are also diagnostic of type 3. And their treatment include anti-inflammatory agents. Now we are going to look at type 4, which is the delay type. Type 4, the delay type. Reaction involves sensitized T cells and release of its lymphokines as mediators and amplifiers. In type 4 delay type, mediated by cells rather than antibodies. They are mediated by cells rather than antibodies. They contact clinical state. They cause contact dermatitis, transplant rejection, and granuloma. THR1 cells release cytokines to activate macrophages, causing inflammation and tissue damage. And this continued macrophage activation can cause chronic inflammation, resulting in tissue lesions, scarring, and granuloma formation. And response starts after 48 to 72 hours. That's type 4. So I have a slide here that will show you the delayed hypersensitivity reaction, the reaction time, the clinical appearance, the histology, and the antigen site for contact dermatitis, for tuberculin, and for granuloma disease. Diagnosis and treatment. Diagnosis tests in vivo include delayed cutaneous reaction, and that's what we call MANTOO test, delayed cutaneous reaction, MANTOO test, and patch test for contact dermatitis. In vitro tests for delayed hypersensitivity include mitogenic response and lymphocytotoxic and IL-2 production. Corticosteroids and other immunosuppressive agents are used in treatment of type 4 hypersensitivity. And running up, I have a comparison of different types of hypersensitivity in a single slide, in a table. So you will see when you get the slide, the type of antibody involved in type 1 anaphylactic, which is IgE, in type 2 cytotoxic, type 3 immune complex, type 4 delay type. And then you will see the antigen, type of antigen, is this exogenous cell surface soluble or tissue organ? You will see the time of response. Is it 15 to 30 minutes, minutes to hours, 6 to 8 hours? You see the appearance. How do they appear? Their histology, their transfer with, is it by antibody, or T cell, and then the examples of the clinical conditions that are implicated. We've been able to handle 3 now. We've done immunoglobulin, we've done autoimmunity, we've done hypersensitivity. All right, let me just take one more. That one will not be, it's not long. Let me take transplantation immunology. Transplantation immunology. I'm sure from our knowledge of immunology, we know what transplantation means. And we are going to look at it involving the self and then the non-self transplantation. So implantation of non-self tissue into the body is called transplantation. Implantation of non-self, that is, you are bringing in from somewhere, is called transplantation. And the process of taking cells, taking tissues, taking organs is called a graft. A graft. From one part or individual and placing them into another individual, usually different individual. We call it graft transplanting. Graft transplanting. So the cell, the tissue, or the organs is referred to as the graft, and it is the transplant from one part of individual and place them into another part of another individual. We refer to donor as the individual who provide the graft, and we refer to the recipient or the host as individual who receive the graft. So on genetic basis is naming different type of graft. So when it is self to self, when the graft is self to self, we call it autograft. Autograft. And that is one individual. When it is one individual to another, we call it isograft. For example, in identical twins, both are genetically similar. In identical twins, you are taking from one individual to another. But because they are identical twins, they are isograft because both of them are genetically similar. Grafts between two genetically non-identical members of the same species are referred to as allograft. If the grafts are taken between two genetically non-identical members of the same species, they are referred to as allograft. And they can be stored or fresh. So grafts can be stored or fresh. Stored in the sense that the individual donated the graft, like it normally occurs abroad. Overseas, we have people that they already knew they were going to die. They will tell them to come and harvest their organs and preserve the organs as a stored graft for whoever we want to use it. And then we have the fresh, which is taken fresh from the donor and transplanted directly to the host or the recipient. So transplant may be living or dead based on the explanation I made above. Live grafts are kidney, the hair, also called as vital graft, while the non-living grafts are the bone, the artery, static, or structural graft. Based on nature of organs, we can classify transplant. We have the kidney, the liver, the heart, the bone marrow, and the spleen on the basis of anatomical sites. We can classify them on the basis of anatomical size. So grafts can be classified. Those grafts that we mentioned earlier on, kidney, liver, heart, bone marrow, skin, can be classified on basis of anatomical size. That is where anatomically they occur. We have autotropic and heterotropic. We have autotropic and heterotypic. For autotropic, we refer to the skin graft. We recover to skin graft. So for heterotypic graft, we have on abnormal site, example, thyroid gland in subcutaneous region. I've explained to us what Allograft means transplant from one individual to another with it's a different genetic makeup within the same species. Example, kidney transplant from one person to any other, except in an identical trait. That is allograft. Isograft, transplant between genetically identical monozygotic twins or between members of an inbreed strain of animals. So that is isograft. We have autograft, transplant from one site to another on the same individual. Take, for instance, transplanting a blood vessel from the leg to the heart during cardiac bypass surgery. And this type of transplant does not require immunosuppressive therapy in autograft. Another type of autograft is the transplanting of skin grafts in burns or destructive injuries from one portion of the skin to another portion of the skin. We also have what we call the xenograft, which is the transplant across species barriers. Xenograft is transplant across species barriers, e.g., transplanting a heart from a baboon to a human. And this one normally have a poor prognosis because of the presence of cross-species reactive antibodies that will induce hyperacute rejection in most xenographic transplants. Allografting have been applied in cornea transplant, skin transplant, lung transplant, blood vessel transplant, pancreas transplant, kidney, heart, liver, and bone marrow. There is a case of transplanting from male to female. We have found out that because male tissue contains SY, so when some male tissues are grafted to a female with SY, with SS, sometimes the female don't contain Y gene, and then the graft may not be accepted due to the Y gene in the chromosome of the male. But however, graft done from female to male are accepted because SS of the female will easily flow. There's no Y in the female. So the phenomenon is called as unilateral sex-linked histocompatibility. In a situation that graft from female to male is accepted, but graft from male to female is rejected because of Y gene on the chromosome. This condition, the phenomenon, is referred to as unilateral sex-linked histocompatibility. It's also known as Edgeworth-Simpson effect. Edgeworth-Simpson effect. Transplant and the immune system. There can be discrimination between self and non-self grafts. And this is not good for transplant. At first, the only response possible transplant were blood transfusions. Otherwise, the grafts were distractions. Why are blood transfusions tolerated? They are tolerated because most of the time, the general blood group differences are not many. And you can easily do cross-matching to eliminate which blood group that are not compatible. It's only in rare cases we have dangerous blood group O, or we have blood that has atypical antibodies that will elucidate a corresponding reaction in the body of a recipient. But in most cases, it is blood transfusion that is usually accepted, the type of graft that is universally accepted. Now let's look at the major concept in transplanting in immunology, the major concept. That is, how does the immune system deal with the transplant? What are the mechanisms of rejection after transplant? What are the current clinical strategies to block rejection? That is, what are we supposed to do to block rejection? What are the new and the future strategies to promote specific immune tolerance? And then what is the role of xenotransplantation? And what is graft versus host disease? These are some factors that we answer the question we said earlier on. Proper blood group compatibility, we assist. We assist in ruling out rejection of graft. And then proper human leukocyte antigen compatibility also. We also guide against rejection of graft of either skin or organs like kidney. And then there is more detailed HLA typing and tissue matching that is more detailed than ordinary compatibility that we can also carry out, that we also assist. And also, the HLA, that is human leukocyte antigen typing, has the ability to identify the HLA antigen expressed on the surface of the leukocyte. So when these procedures are properly carried out, it will guide against the rejection of the organ. So immune response against transplant depends on the presence in the grafted tissue of antigens that are absent in the recipient, and hence they are recognized as a foreign antigen. There are phases of rejection of grafts. We have the hyperacute rejection, which occurs in minutes to hours. For example, pre-existing antibodies to donor HLA antigen, and then the complement activation or macrophages. They occur as hyperacute rejection. Number 2 phase, we have the accelerated rejection, in which the rejection is accelerated because of the presence of pre-existing antibodies. And then we have the acute rejection. This occurs around 10 days to 30 days. This one is majorly cellular by cellular mechanism, by macrophages, CD4, CD8, or NK. And then we have the 4th phase, which is the chronic rejection. This one takes place months to years. And this one is mixed humoral and cellular mechanism. And it's been recorded that chronic rejection is still hard to manage. If the recipient possesses all the antigen present in the graft, there will be immune response. If the recipient possesses all the antigen present in the graft, there will be immune response. And there will be immune response, and there will be no immune response, and no graft rejection, even when the donor and recipient are not synergenic, in the sense that the individual is able to accept the graft. So there is a condition that we have seen, that the antigen present in the graft, the recipient possesses the antigen. So therefore, it's not possible to produce an antibody to the antigen that are in the graft. So therefore, they don't react, they therefore accept the graft. Now, what happens after 2 to 3 days? The site around the transplantation will be inflamed by lymphocytes and macrophages, and blood vessels will be occluded by thrombi, and vascularity to graft will begin to diminish, and ischemic changes will begin to occur, and scalp-like changes will begin to appear. Slurs out 10th day will be produced, and then this is referred to as the first set of immune response to graft. What happened therefore in allograft rejection? Skin from one animal is accepted initially, is vascularized, and appears healthy for a short period for 2 to 3 days, and then inflammation will set in, and rejection process will begin to occur. As we said earlier on, hyperacute rejection occurs within a few minutes to a few hours. It is a result of destruction of the transplant by preformed antibodies, which are cytotoxic antibodies, and some produced by recipient before transplant. Some are generated because of previous transplant. Blood transfusion and pregnancies are examples. And these antibodies activate the complement system, then platelet activation and deposition, causing hemorrhaging and swelling. This is cell-mediated immunity. In chronic rejection, it is caused by both antibody and cell-mediated immunity, and may occur months to years down the road in allograft transplant, after normal function has been assumed. After normal function has been assumed after the transplant, important to point out is that the rate and the extent and underlying mechanism of rejection that vary depending on the tissue and the site of the transplant. So depending on the tissue, depending on the site, that will determine the method, the rate, and the extent of the rejection process. So the recipient circulation, the lymphatic drainage, the expression of the MHC antigens and other factors also are involved in determining the rejection rate. So in chronic rejection, we have inflammation, we have smooth muscle proliferation, we have fibrosis, and we have tissue ischemia. What are the laboratory tests that we can do in this particular transplantation. We have ABO blood typing. We have tissue typing, that is HLA machine. We have lymphocytotoxicity test. We have mixed leukocyte reaction. We have screening for presence of preformed antibodies to allogenic HLA. Cross-matching also is also involved. There are diseases referred to as graft versus host. Graft versus host disease, which can occur in the special case in which the immunocompetent tissue, the fresh whole blood or thymus or bone marrow, is transplanted into an immunocompromised host. So the T cells from the transplant recognize the host major histocompatibility complex molecule as non-self and begin to attack the host. So this is a type 4 hypersensitivity reaction, and the antibody plays no role at all. Antibody plays no role at all. It's the T cell from the transplant that recognize the host MHC molecule as non-self and begin to attack the host. So that's an example of a graft versus host disease. We have bone marrow grafts. An attempt to use this have been around for at least 60 years now. It is explored intensely since World War II. Bone marrow is used for treating blood diseases, severe combined immunodeficiency, and leukemia. So bone marrow transplant is used to treat blood diseases. And this type of transplant is also called a form of gene therapy, whereby the bone marrow of a normal individual is moved into and grafted into an individual that is sick. There are different sources of stem cells for transplant. We have the peripheral blood stem cells collected peripherally using apheresis, that is self-separator machine. They are less invasive. It has less discomfort. It causes less discomfort and then less mobility than bone marrow. And then outpatient procedure result in more rapid hematopoietic recovery. There's no difference in treatment outcome and quickly replacing traditional blood bone marrow. So we use cytokine stimulation. Bone marrow release large number CD4, CD34 stem cells into circulation. These stem cells are vested via peripheral line. There are situations that leads for GVH, which is graft versus host disease. Allograft in a recipient in whom specific immunological tolerance has been induced. Yes, it's a situation that leads to GVH. And then the present with clinically retardation of growth, people that present retardation of growth, people that present with diarrhea, hepatosplenomegaly, people that present with lymphoid atrophy, people that present with anemia, and then terminating fatally, or syndrome that is called Run disease. These are possible situations that lead to graft versus host disease. So, thank you for joining me tonight in this particular session. So, I don't know if there will be any question, or maybe you can reserve your question till next lecture when you will have received the slide and you will have gone through, and then we'll take the questions together. So once again, thank you for your patience.
Thank you so much, sir.
Thank you very much.
Very interesting topic. Thank you so much, sir.
All right, God bless you, Esho.
Yes,
so I will send the slide to the class rep immediately. The first slide.
All right, sir.
Let me see if my network is back now. Thank you.
Yes, sir. Thank you so much, sir.
Yeah.
Captain, well done.
Yes, sir. So I'll be sharing the YouTube recording. When you get to when you land on my page, like my page and subscribe. Otherwise, I will not.
Okay.
I feel like
We will do that.
Problem, we go like them. Send them to your YouTube.
There are even other recordings there too.
In
That we
fact,
can
No
look at.
problem. We'll go for it.
Yes.
I go love your page.
All right.
Well done, sir.
Thank
Thank you.
I hope we are working on our
Group assignment?
group assignment. Yes.
Yeah.
So I don't know if Mrs. Adetogun will still be taking us tonight. If we are up to it, do we still have strength for another lecture today?
No more lectures today.
What time?
Let's rest too, since morning.
Okay, tomorrow then, possibly tomorrow evening.
No more lectures.
Okay, noted, ma. So the may have it. All right.
Let me see that bag. Is there another one?
Good night then.
Along with
Good night, everybody.
Good night, sir.